Steve Whitney, President and CEO of Albert Kahn Associates. I was asked to participate in this because we have a long history working here at the University of Michigan Medical Center. But let's start out with a little history of the medical center itself. Since 1850, the medical center has been a leader throughout the nation and in fact throughout the world in leading diagnostics and providing constantly improving care for their patients. In 1919, the university hired Albert Kahn to design what was then the new University Hospital. But unfortunately, the university ran out of money, and therefore the core and shell was all that they could build. But 2 years later, they came back and, with Albert Kahn's help, finished the entire building, and it opened as state-of-the-art and remained the major teaching hospital here at the university for the next 65 years. In 1950, Louis Sarris was hired to design the first women's hospital, which is still in use today. The University of Michigan Medical School opened to medical research and teaching facilities in the late 50s. In 1969, Albert Kahn Associates was again retained to design the new C.S. Mott Children's Hospital. The firm was brought back 25 years later to renovate and expand the facility. Also in 1969, Alden B. Dow was retained to design the Towsley Center for Continuing Education. In the mid-1970s, it was determined that in order to keep pace with the ever-changing world of medicine, University Hospital, or Old Main as it was called, needed to be replaced by a much larger, state-of-the-art facility. The firm of Albert Kahn Associates was again retained to begin the planning and design. This is where my involvement began. In August of 1979, I was asked to join the firm to be the project architect for the Replacement Hospital Project, or RHP as it was called. I had cut my teeth on large, complex projects in Boston and Minneapolis following my graduation, so understood how they needed to be organized, staffed, and produced. For the most recent 2 years, hospital design was all that I'd been doing out of St. Louis. Numerous sites and massing options were studied. Maintaining a close relationship with the existing medical school was of paramount concern. Kahn convinced the university that separating the ambulatory patient clinics into a separate, less expensive building not only would save money, but reduce the cross-traffic between inpatients and outpatients. Thus, the Alfred A. Taubman Healthcare Center project was begun, designed in partnership between Hanson Lynn Meyer and TMP. Since these two projects were going to be designed and constructed at the same time and would interconnect on every floor, it was very important that the architecture be seamless and building systems be compatible. The architecture of the RHP was truly form follows function. Conceived as an all-brick structure, large precast panels were substituted on the bed tower floors to reduce weight and to speed up construction. Bed tower windows were mounted low enough that patients could still see the ground from their beds. Large expanses of glass were used wherever possible to maximize visibility and natural light. The RHP had set the design standard for all new facilities in the medical center since its construction. Minimizing patient and visitor stress was a key factor in the planning of this 1.25 million square foot hospital. Therefore, organizing primary circulation along the southern outside walls to help in orientation and wayfinding was of primary concern. This focus on orientation was extended to the vertical circulation as well. All major vertical circulation was organized into 2 north-south service zones at quarter points along the building and are strongly expressed in the building massing. These zones include 2 major public elevator cores next to the primary circulation along the south wall, 2 major patient and staff elevator cores provided at the north edge of the inpatient tower, 2 major material handling cores were provided where elevators open directly into marshalling rooms for supply distribution, and public restrooms, electrical communication closets, as well as major duct and pipe shafts were located in these same zones. Between the service zones are long-span structural bays. By minimizing columns, services, and utility interruptions in these bays, the planning flexibility was maximized. Interstitial space, or building services and utility levels, were inserted between each of the three main diagnostic and treatment floors in the building's base to maximize flexibility for change and to minimize disruptions to adjacent areas when new technologies were being added on an ongoing basis. The deciding factor was the fact that in a major teaching hospital, operational costs exceed construction costs in only 20 months. 20 years after completion, this decision was still paying dividends. One half of the 600 patient beds in the RHP were put in private rooms. By interspersing the private and semi-private rooms, the deeper semi-private rooms cantilevered out from the building, setting up a rhythm on the exterior that effectively broke up an otherwise potentially very long flat facade. The bed units had both central nursing stations as well as 8-bed nursing command posts for the nurse's direct contact with her 8 patients. Each patient room was designed with compartments to house all medications and supplies immediately next to the room. Many private rooms, the nursing command posts, and the bedside supply system, all of these concepts are viewed today, 20 years later, as cutting edge. The RHP was the first State of Michigan funded project to be built using the fast-track methodology, and the project had over 90 prime contracts. As a result, our staffing for this project needed to be set up to accommodate the aggressive construction strategy. We organized the architects into teams focusing on the building interior areas and the building core and shell, the structure, enclosure, elevators, stairs, and building equipment areas. The interior teams were separated to focus on the inpatient unit, or IPU, tower, and the diagnostic and treatment, or D&T, base. These were individual assignments to major functional areas such as surgery, diagnostic imaging, emergency department, diagnostic laboratories, the cancer center, pharmacy, central sterile and materials handling, as well as kitchen, dining, admitting and discharge, and public spaces. My job was to hold it all together. I think we did. The RHP and the Taubman Center opened in February of 1986, under budget and ahead of schedule. Following a failed attempt by the community to have it saved, Old Main was torn down in 1989 to make room for future medical projects. In 1995, the last of the 3 medical science and research units were completed, designed by Jickling, Lyman, and Powell. In 1997, a new cancer and geriatric center opened, designed by the partnership of Hansen Lindmeyer and TMP. The projects continue. There are 2 major medical center projects in design and under construction at this time. The Ambulatory Surgery Center and the Rachel Upjohn Depression Center, both designed by Albert Kahn, are opening on the East Ann Arbor campus. On July 11, 2006, the Medical Center hosted a 20-year anniversary dinner and celebration for the Replacement Hospital project. I guess we did okay because we were invited to attend. The University of Michigan Medical Center is doing everything necessary to remain the premier healthcare provider in Michigan.